the start point.
Thank you. We have something funky going on with our name in this front slide, so hopefully the rest of them won't be as ridiculous looking as that one, so my apologies on that. But good morning, everyone. I'm Lisa Dillard, and I am with the Division of Strategic National Stockpile. And on behalf of our director, Mr. Greg Burrell, we're very pleased to be here with you all because we take a special interest in championing some of the work that CDC is trying to do with federal agencies to help support what you all are doing out in the state and local jurisdictions. And this has been an effort we've been working on for quite a long time. And I guess the presentation that Joe and I will give you today is sort of some background and context of where we've been with trying to bring the federal agencies on board to support your planning efforts so you can get a better idea during this workshop of how we're going to frame where we're going forward as you continue to work with your state and local federal agencies. So just all of my slides apparently are going to have this little crazy piece going on, so we apologize, but just to give everyone a quick background of what the Strategic National Stockpile is, and I see we have a lot of folks from various jurisdictions. Can I see by way of hands those are directly involved in your planning for Strategic National Stockpile receiving distribution in this thing? Okay, others are pretty much a supporting role in that, in public health. Okay, very good. And by show of hands, those that have been doing that for 5 years plus? Okay, there's the vets around here, huh? Okay. And those who just got hired yesterday and the boss said, go to this meeting. Happy great intern. Okay, wonderful, wonderful. So that's, and about 2 years you've been doing this and struggling to do some outreach, anybody? Okay, so pretty much we've been either doing it a long time and progressing forward and still having challenges, or we're just starting and trying to improve, so that's good. So just by way of quick background, really nothing's changed in the Division of Strategic National Stockpile. We're still here to support a public health emergency, primarily designed to support those DT events, but as we have progressed over the years, we also include countermeasures to support all hazards events. And one of the key things that we're striving to do within our enterprise at CDC is ensure we're able to deploy these assets to your local jurisdiction in the least amount of time possible. Because as you recall, for the City's Readiness Initiative, in particular DT events, time is of the essence in getting countermeasures into people, which makes this problem set very challenging for us. Community resilience activity is the group that I lead within CDC. About 2.5 years ago, 2 years ago, we used to be a group or branch within the Division of Strategic National Stockpile that was called Program Preparedness Branch. And that branch was the group of folks that were responsible for coming to your jurisdictions, whether it's state or CRI local jurisdiction, and conducting your technical assistance reviews and giving you the great score and coming back, and everybody remembers the TARs and whatnot. So that's the group that we were within the Division of Strategic National Stockpile. We had an organizational shift about a year ago, so that function has left the stockpile and gone down to the Division of State and Local Readiness, and Captain Tom Bowman, who walked out, but I'm sure you all know him. Perfect timing. We couldn't plan that even better. Captain Tom Bowman is the Deputy Branch Chief for the Program Services Branch that now has that function of the technical assistance reviews. But the folks that remain behind in the stockpile, like myself and Joe Vitale, we're sort of continuing what used to be an additional duty for us in trying to promote partnerships for you all at the national level. A lot of feedback that we got during the beginning of trying to develop alternate methods of dispensing was we're having trouble getting CEOs on board, we're having trouble getting federal agencies on board. At our local level, we get the person who is responsible at the local jurisdiction, they understand about countermeasure dispensing, they want to be involved, but as soon as they try to get this MOU up to their headquarters for permission, everything stops. So we took the approach of trying to come in at the top, where myself and Mr. Burrell would go and speak to heads of federal agencies and try to get them to understand the problem, and hopefully we would merge in the middle with you all hitting the folks at the local level, us coming at the national level, and we make a great sandwich in the middle, and you have partners. So that's something that we felt was still important, still needed to occur, so that's what our organization now within the stockpile is pretty much doing. So we are supporting your capabilities from the SLR. You've received that funding to support this type of planning, but we're trying to help you all engage and expand your dispensing networks with additional partners. To talk about some of the road that we've traveled in this, we were really able to get some traction behind this coordinated effort back in 2007 with the development of Homeland Security Presidential Directive 21. This is something that went out to the federal community that says, hey, pretty much there's this issue about community resiliency, there's this issue about supporting state and locals with assets that you may have in your local jurisdiction, and we want you all to get engaged. So it's pretty much our first step in policy alignment or in a directive that told federal agencies this is something you need to do at the local level. We jumped on board with that at the stockpile and started to engage the federal agencies, DoD being in that group, through federal executive boards. And Oregon, I heard Kansas City, or I heard Kansas was here. We went around to pretty much all of the 28 federal executive boards. We were invited to participate in their emergency preparedness meetings. It had heads of all federal agencies within those jurisdictions, and we talked to them with the state and locals about countermeasure distribution and dispensing, and potentially how they could become involved at the state and local level. And we gave the secret federal handshake to our state and local partners and said, these guys are part of your community, go ahead and help them with some needs that they may have, help close some gaps that they may have in planning. And the federal agencies, a lot of them, or the federal executive boards, jumped onto this. And I have on this slide two that I really want to highlight. Region 7 and out in Region 10. Kansas City, I heard Kansas was here. Okay, Region 7, Bonnie Martin out of Kansas City has done a fantastic job through her federal executive board in planning and exercising and testing. So if you're looking for some examples of that, Region 7, Bonnie Martin, Kansas City is a very good one to reach out to. And Portland, I heard Oregon, Washington County was around, yes. Adrian Donner and Kristen Cochran, I'm never going to attempt to pronounce all those counties involved in that CRI jurisdiction, but there's about 6 in that CRI jurisdiction. That used to be Joe's area when he was doing TAR. So they also just recently did an exercise with their federal executive board, which was phenomenal. We were able to go out and observe those actions too. So you have some examples, and I'm sure there are other federal executive boards that are coming along in planning. Some are still coming back to us asking if we can help them get further engagement. But I do know in the Dallas area here, the federal executive board is coming on in some of the planning initiatives. I say this is important because if you have DoD within that jurisdiction, they'll be a part of that federal executive board also, so that could potentially be another outreach effort for you if you're trying to make contact with the installation. Another thing that HSPD 21 did for us is it gave us a little bit of traction with some federal agencies that got it immediately. I'm going to have the VA be read up here because and Aaron's going to talk, because they got it back in about 2007, 2008, but then they kind of didn't get it anymore as some people changed positions. So it's taken us a while to get the VA back on board with supporting your planning efforts. But at the time, the IRS realized, listen, we want to be a part of this effort. We realize our employees are important. They're within the community. We want to be able to help dispense medication to them, but we can't really participate with other federal agencies as closed pods because we have so much information that we kind of need to keep secret. So we'll do it, but we'll have to do it by ourselves. And in a lot of jurisdictions that had IRS facilities that had thousands of employees, this was a big deal. I know in Missouri, this has been some good planning going on and testing and exercises. So the IRS in some of your jurisdictions is also on board. If you have been and you haven't reached out, I would encourage you to. And GSA, in 2012, we did a pilot with GSA for the 10 regions, GSA headquarters, and they said, okay, talk to us about how we could be closed pods for our federal agencies, because GSA is normally the landlord of the federal buildings within your community. So they felt that they could actively be able to serve in that close pilot manager role. And we had some success with those pilots in 2012. So that shows you how we started to get some of the federal agencies involved over the history of time. And Joe's going to talk to you a little bit more about this new great executive order 13527 that's really been able to help us get traction and support your efforts to bring folks on as partners in distribution and dispensing.
Okay, hey, good morning, everybody. Again, I'm Joe Vitale with Community Resilience Activity, Division of Strategic National Stockpile. And briefly, just a little bit about myself. I used to work for Georgia State Public Health as a SNS and preparedness coordinator for several years, as a colleague of Pam Blackwell's for several years. So it's good to be back here with Pam and reminiscing about old times and such. So I get the task of trying to make you understand the policies and how we are working through this issue with federal rapid dispensing of countermeasures and such. So I'm going to try to do that with as little as government ease as possible. So basically, what we've done is kind of, you're going to see that we've developed this presentation in kind of like a chronological order. So what I'm going to do first is talk about the executive order, explain what the executive order is, and then we're going to talk about how the executive order was mandated the development of a federal countermeasure rapid dispensing concept of operations. And then I'm going to talk a little bit about what DOD's role had been and how they were tasked to do what we call a commander's estimate, which was to look at the medical countermeasure dispensing activity and how DOD could support that, and what concepts or courses of action they came up with and what decision they came up with. So just a little bit about the executive order. Actually what it is just the executive order is to develop a federal rapid countermeasure dispensing to support state and local public health in the event of a biological incident. And the federal interagency concept of operations, what that did was it outlined how federal employees could be mobilized to support medical countermeasure activities in the event of a biological incident. The distribution of federal employees, how they can be used to help support local public health at the points of dispensing or at state public health as we see in the distribution process. Also identified federal rapid response teams such as the MDMS teams, Public Health Service, DOD personnel as we have highlighted down there, and other types of federal support agencies that could respond to support state and local activities. And also was the concept to develop pre-registered federal volunteers that could move from their point of work where they work and then to support a pod or any type of other federal or state and local medical countermeasure dispensing and distribution at the time. So I'm just going to talk a little bit about the commander's estimate. What a commander's estimate is that the commander gets a mission. So back in 2011, the National Security Staff tasked DOD with identifying how they could support medical countermeasure dispensing and distribution. So they were given the task of seeing what DOD could do to support that effort. What they developed was 3 courses of action. These courses of action were based on how they could support the National Capital Region, Chicago, and Los Angeles in event of a medical countermeasure distribution, dispensing, or biological attack. And what that does is the commander's estimate outlined 3 courses of action that the local base commanders could use to support medical countermeasure distribution and dispensing. So I'm going to go through, and I can't have this memorized, but I'm going to read them to you real quickly. So the first course of action was to use locally stationed DOD personnel to support state and local missions that were involving medical countermeasure distribution and dispensing. The second course of action was to use specialized teams of CBRNE forces, which is chemical, biological, radiological, nuclear DOD personnel to support state and local efforts. And the third course of action was to use a combination of locally stationed DOD personnel and CBRNE staff to support the state and local effort for response to a biological incident. And as a follow-on to this, Commander Guide is going to explain the policies and all the intricacies that go along with how we institute support from DoD in a public health emergency. So I have been given the task of working with FEMA for the past year now on the executive order planning that they have been tasked with to do for the top 10 U.S. and cities as listed above. It was kind of like swimming up water at first because FEMA didn't really have an understanding of what has been going on for over the past decade at the state and local level for biological event planning, medical countermeasure distribution, and dispensing planning. So we had to kind of start from the beginning with them and explain to them that this is what the mission of the Strategic National Stockpile is, this is our response capabilities, this is what has been going on at the state and local level for years, for the past decade, and these are the capabilities that have already been developed. So once we got them on board with the information and the planning and everything that has been going on at the state and local level, the process seems to be going a lot smoother now. We developed a pilot with Los Angeles County back in 2012, where we developed support plans based on the executive order intent to support Los Angeles County for federal support to medical countermeasure distribution and dispensing. Currently, we're working with Chicago, New York City, and New Jersey, and actually Dallas-Fort Worth area for EO planning for this year. And then in 2014, we're going to be moving to Washington, D.C., Philadelphia, Boston, and San Francisco. I'll turn it back over to Lisa.
So in this effort of getting federal agencies on board to support countermeasure distribution and dispensing planning, as Joe said, it has been like swimming upstream, but we have a lot of traction now, and especially with some new policies that DoD has developed in response to the executive order, we think it's a perfect time for us as public health authorities within our jurisdictions to, I don't want to say strike, but engage. Is that a nicer term? Engage. So in doing that, based on our experiences, a couple of things I want to run past you as some key points, and hopefully we can help develop and flesh these out during our discussion during the workshop. But the executive order has helped us with progress, and authorities do exist within the Department of Defense that Commander will speak to that support local planning efforts with the DoD installations within your jurisdictions. I want to dispel the planning myth that has plagued us for years as we engage partners in that the feds can take care of themselves, and that is a myth. And if you're still hearing that, I would charge you as public health authorities to push back and ask further questions, because what they're probably telling you within the jurisdiction is they have some type of cash, and I would relate it to some type of, like you have your first responders who may have some type of cash that's designated for a specific small population. But when you think about the problem that we're trying to support here, countermeasures into your entire population within 48 hours, not so much that they would have those types of resources on board. Those types of resources come from the federal government, the Strategic National Stockpile, to your state. Unless you're a directly funded city, they'll come directly to you. New York City, Chicago, LA, or the district. But those are the state's responsibility to get them down to the local level, and then your responsibility as local planners to get them to your entire population. So I'd like to just keep that in mind as you're planning. And also, one thing that I would recommend, based on the feedback we've received, not only in working with the federal partners, but from private sector also, is we need to get a handle as public health on these MOUs and MOAs that we're presenting to potential partners, because they are holding us up. They're holding us up once the legal folks get involved, and if you've cracked that code, I would ask you to share it. We tried about 5 years ago to develop a national level MOU, didn't work. Your states and your local authorities are not willing to give up that right that they have to manage these things on their own, so we gave you a template to use. But there's some creativity going on out there, especially out in Oregon, and we jumped on what Oregon is doing with provider enrollment forms, provider agreements that are a little less intimidating. They get the same point across. I think Georgia's adopting some of that, and Dallas may be adopting some of that. Because especially if you're in a jurisdiction that has multiple county lines within it, and you want to work with an agency that may spread across different counties, they don't want 5 different MOUs, and that's going to hold you up in your getting a partner. So if we can work on that as public health, and we at CDC will help with getting those templates that we have out to you all, that is a big piece of solidifying your partnership. And then also, if you are exercising, which of course we hope you will once you get your partner, but there are examples of folks who have the MOU and the collaboration stops. We have to take it all the way through to an exercise. If you need some support with that, please contact us. You have friends out there who are doing it. They have tabletops, they have templates already written, and we can hopefully start sharing those things in the future. So with that, I will turn it over to my DOD colleague who's going to come up and speak to you about support to, well, CDC and support to DOD. And I don't know if I have your slides up.
Just keep looking.
Okay.
There you go.
Awesome. All right. We started slow going.
It looks like his font is in the right place. Or
You know, I hate the DOD folks.
Spit the polish.
Yes. Awesome.
Thank you very much. You as well. Well, thanks, Lisa. Thanks, Joe. And good morning, everybody. So hopefully I can clarify a few points. It's very hard, you know, when you talk about all hazards to get into the particulars, of every type of response and how DOT can respond. But I'm going to go over some of the basic instructions and directives and provide some insight for you guys. How do I advance this?
Just the arrows.
This one right here.
Okay.
Okay.
Just the arrows. There you go.
So there's two key documents I'm going to go over in this talk. One is the Department of Defense Directive 3025 TAC 18, which talks about defense support for civil authorities, and the other is DoD Instruction 6200 TAC 03, which talks about public health emergency management within the Department of Defense. So we're all pretty much familiar here, hopefully, with strategy for HD and DISCA, and you know, really the priority mission 2 is kind of what I'm going to be focused on here a little bit more, and that's just overall maintaining preparedness for sea burning type things and developing plans for DISCA. So a couple of the two key strategies which relates here is about promoting federal and state unity of effort and conducting integrated planning. So those are the key components here, and that's not an easy thing to do because I mean it's all about relationship building, right? With CDC, with your partnerships out there, it's about talking to people. You have to remember there are a lot of statutes. There are different barrels of money that you know, things have to be done very appropriately when you go from one agency to another and ask for help. It's got to be paid for at the end of the day. So I'm just going to go over a little bit on this directive, the 3025-18, which again, it's a DISCA. It's basically Department of Defense forces and National Guard responding for requests for assistance by civil authorities. I think a really key thing for everybody here to understand is the difference between active duty forces and National Guard. Are most of you familiar with the difference between National Guard and active duty? I hope so. It really is key. National Guard are Title 32 forces. They are under the command of the governor, okay? And so they can conduct any sort of state-funded operations or emergency response. But they can also be federally funded and still be under control by the governor if it's authorized by the SecDef under certain circumstances, okay? They can also become Title 10 forces, which is unique. So Title 10 forces are active duty military forces. We can't become Title 32 forces. But Title 32 forces, National Guard, under circumstances can be federalized to help out in both homeland defense and globally for things. And when they become federalized, they then are no longer under the control of the governor, but are under the control of that local or that geographic combatant commander. So that would be like, for example, in NORTHCOM, in the NORTHCOM commander in these type of situations, if they're federalized. So hopefully most of you guys have already taken that into account and probably been talking to your National Guard counterparts or leads in your planning efforts. So essentially, this directive basically just establishes the DISCO policy, and the key here is that when DoD is asked to help, it's a formal process, and there's a request for assistance. It's usually by the governor, and there's also, as I sort of alluded to earlier, there's discussion on mechanism of reimbursement, and there are cases where the president can say you don't have to reimburse. But that's always a consideration because DoD to come in and assist is very expensive. Now, with that being said, if it's a real issue, if it's a real hazard or issue, DoD is going to, they're going to go in and help. If the president and the SecDef says go help, we're going to go help, and we're going to worry about reimbursement and work through all those issues after the fact. Okay, and you see these often with hurricane response. The president may say, DoD, lean forward, support, and we'll go out there and we'll try to provide logistics support, whatever we need to do. And oftentimes things aren't reimbursed. I mean, we will try to do our best to assist in those things. But that is a part of the process is the reimbursement part. So. And I guess the key that goes right into this next slide. The key point is about DoD is usually the last in and the first out, just because of the expense related to having DoD forces. There's a couple there's a couple of key points here. Obviously DoD only would become engaged if things are just in a very bad situation where the local civil authorities can't handle things. There's breakdown, and you have to know that if there's a war going on. And other significant military operations, those things still are priority for DoD unless the SecDef says otherwise. So the other thing I think another important point to realize is that military forces aren't, in an emergency response, aren't ever going to be carrying weapons to serve as law enforcement. They don't do that. Now, now National Guard can provide support through the governor in a different way, but the DoD forces themselves are not going to be carrying guns around in these cases. So this slide just kind of goes into like how local installations can help out at the city, county, local level. So there's something called the Immediate Response Authority. So this will allow federal or DoD installation commanders or governments or DoD government service officials authority to provide temporary resources to save lives if things are really bad. And usually that's done within, we look at a 72-hour window. So they can respond immediately. Like that installation commander has authority to do it. If it goes on beyond 72 hours, then it becomes a more formalized process through the SecDef and so forth. So the installation commander does have autonomy in these regards to help out. And again, a lot of this is based on communications and plans and agreements and sort of the discussion agreements that are already in place. Talking about those agreements, you guys all understand the type of agreements that are out there, and I'll get into this a little bit more, but basically memorandum of understanding, memorandum of agreement, mutual aid agreements, and really the memorandum of understanding is basically just general understanding between two parties. There's really no specific commitment, but it's just about communication and saying this is what we could do if we need to. The memorandum of agreement usually basically talks more about commitment of resources, and then the mutual aid is, although non-binding, it basically is a commitment to provide resources if needed on both sides. So, and so at a state and local and city level, like if you have a military installation nearby, it's important to reach out. It's a two-way street. It's important to reach out, and I'll talk a little bit about the right points of contact. And many of you probably know this, but there is a public health emergency officer, that's an installation. Sometimes it's regional. You know, for example, every large military installation has a public health emergency officer, but sometimes you also have a regional one because you might have reserve components out here that are very small installations. And another person is the military treatment facility emergency manager. Excuse me. And so by military treatment facility, we mean a hospital or a clinic. So not every installation per se would necessarily have a hospital or clinic, but if they do, they have a military treatment facility emergency manager who works with the public health emergency officer as well as the installation commander and for emergency planning and support. And those are a couple of key folks you can reach out to try to establish MOUs, MOAs, etc. So now I'm going to talk a little bit about the public health, the instruction on public health emergency management within DoD. Obviously, it focuses on all hazards. And this instruction basically, and it's not that old, but it really clarifies the roles of the military treatment facility and installation commanders, as well as the public health emergency officer and the military treatment facility emergency manager. And the key point here is that it really is, a key component of this document is it really talks about relationship development and sort of in line with the executive order of developing the responsibility of the commanders, these PHEOs, these MIMs, these military treatment facility emergency managers, to develop relationships outside the gates, outside the fences in their planning efforts. It also authorizes Department of Defense installations to serve as sites for closed pods, not open pods, and I'll get into that a little bit later. So, but they have to be closed pods. Closed pods meaning inside the fences, Department of Defense beneficiaries and Department of Defense personnel. And it also allows them to serve as receipt, staging, and storage sites for SMS assets. Also, a couple other points, their Department of Defense has labs in laboratory response networks, and also they deal with issues on disaster mental health response. So I'm going to talk a little bit about the public health emergency officer. So kind of gives you both what their responsibilities overall and sort of the general qualifications. So as I said before, each installation will have a public health emergency officer, and that's sort of the key public health lead at that installation. And that person makes sure that the commander has good situational awareness on all public health issues and any sort of public health preparedness and strategy, and advise the commander on declaring a public health emergency. Again, the key here in red, that person should be coordinating with state, city, local, civilian authorities. And I'll qualify that by saying we had a public health emergency management work group in DoD that was like 2 years in the making, where we just developed a course to train Department of Defense personnel, like PHEOs and these MIMs I'm talking about, because what we found is that it used to be collateral duty, right? You show up, and if you're a doc and you have an MPH, you're like, hey, you know about public health. You know, you should be the point of contact. And so you have to understand, we docs, we rotate every 3 years. That's part of the issue, is continuity here. And so if you show up, and then all of a sudden, I don't know, H1N1 hits, and you've never been involved in coordinating or planning, and they ask you to dust off a binder and figure out how to work with your local counterparts, it's not going to work too well. So we understood that. We also realized that you have different levels of experience, right? You could have an MPH, you could be a 32-year-old doc with an MPH, you could be a 45-year-old doc with an MPH, or you might be right out of your residency training and with your MPH. And so we understood that some of these docs knew that CDC, for example, was a website, but hadn't had much interaction with CDC. And they certainly hadn't had much interaction with their local and their county public health department. So we essentially set up a course, a credentialing course, if you will, to train those public health emergency officers, and we, in all the services, Army, Air Force, and Navy, And the first year, I think we did 4 courses. The next year, we did 4 courses. This year, we're going to do 3 courses, I believe. Dan, is it 3 or 2? 2 this year, because we did the catch-up, sorry. We did the catch-up, and we feel like we got most everybody trained. And there was actually a large pot of money put out there so that even commands wouldn't feel like, oh, we're too strapped, we can't send our folks. So it was like free training for those commands. So we've gone a long way with this. And so one of the points you made, I think, in the introduction is that, or someone made, is that they feel or hear that DoD is now reaching out more. Well, part of it is this effort, because the common point we found home to these guys is the first thing you do when you become the PHEO or the MIM is you start reaching out to your local county health leads. And again, it's a two-way street. If they're not reaching out to you, find out who those people are and reach out to them. It's not that hard. You can make a couple of phone calls and find out. And if you have dialogue ahead of time and get their understanding, you can go a long way. And just a little bit about the qualifications of the PHEO before I get too far off track here. Basically, and I alluded to this, they're usually, we typically try to get the most senior health professional at that installation. It can be variable depending on the installation, but it usually is the most senior health professional there. It can be active duty or government service employee. We like to see that they are clinician, have an NPH or at least 4 years of experience in public health, and they also have an IMS training, so public health emergency management training. So the military treatment facility emergency manager, also same thing applies as I was commenting. And usually, again, their focus is to work closely with the PHEO and to ensure that any sort of emergency plans that they have are well coordinated with the overall installation, not just the hospital, but the whole overall installation, and the local civilian authorities. So again, a great point of contact. And those folks, again, basically the same sort of qualifications, except they don't have to be a clinician or have an MPH, just emergency management training. So the point of this slide, just with the instruction, is that this, the instruction identifies the concept of PHEO MIM, but there's reach back. Each of the services have responsibilities to make sure this happens. Okay, it's just not at the local installation. This goes up the chain. And the goal here is to provide or push folks to make sure that the military commanders are participating in local public health planning and understand the issues of pods and closed pods and SNS. So, and everybody pretty much knows what the military commander of an installation. So, just to break it down, that's the guy in charge. Okay. So you have an installation, again, I wanted to differentiate. So you have the installation, which is a base. So you have a base or an installation commander. And then you might have a hospital in that base. You might have a commanding officer of that hospital. But the installation commander is still in charge overall of the installation. And again, so if you're a doctor at a hospital, your hospital commander will appoint you as PHEO, but that's in coordination with the installation commander. They decide who that person is, and that PHEO and that MIM are going to have communication with both the installation commander and the hospital commander during times of emergency. And again, I've talked about most of these things, but that installation commander obviously is going to be aware of SNS issues and the RSS sites and closed pods issues. So just in closing, how am I doing on time?
Yeah, we're good.
You're fine. Okay, so I'm sorry if this is going a little long here. So I just wanted to declare, myth is a strong word, but probably these are kind of common things that I hear when I'm talking to people out and about, going to meetings. And the myth here is, in a public health emergency, the idea is that a lot of people think, well, maybe DoD is not going to be affected as much as we are, because their clothes are protected, they have all this great stuff inside the gates. But that is a myth. That's not the reality is that now most personnel and their families, I don't live inside the base. We do have some housing on bases, but it's typically limited. Most of us live out in the general community. Our families live in the community. We know that a fence is not going to be a barrier to any all hazards issue necessarily. And so we're going to be affected the same way the community is. And another myth here, that the Department of Defense installation is going to have enough medical countermeasures to take care of all of its active duty, all of its beneficiaries, and that we're not going to need any help from the local public health folks. That's again not going to be the case because depending on the installation, so DoD does have stockpiles of stuff. Okay, it's not the same as Strategic National Stockpile. We have stockpiles of countermeasures. It varies among installations, depending on the number of personnel, depending on the function of the installation. And those countermeasures are really basically planned for mission essential personnel and folks that are going to go to combat areas that need those things, okay? So it's not everybody. So basically, we sort of say, you know, if there's a real crisis, these are the folks that are going to we got to keep the base running. So those are the folks that are going to get the countermeasures. And so we're not going to have enough countermeasures for everybody. So we're going to be, that's why this is so important to talk and communicate and understand that and work hand in hand. And then the last one here that I'll go over is a little bit talk about open pods. And so, by the way, I'll just say before I go into this last myth here is that it's been, I really in the last 2 years, I've just seen a really amazing growth in conversation and connections with CDC, HHS, DOD, DHS. We're all sitting at the table and we're really talking. It takes a long time because, you know, we're all so siloed and there's a lot of bureaucracy. But I think we've come a long way. And I think, you know, even with regards to pandemic planning, and it's like, hey, how can DOD come out and help give more shots? If we, you know, like in the case of the pandemic, how can we medically support? These conversations are going on all the time, and I think we've come a long way. This takes me into the concept of the open pod. DOD can have open pods, and the reason they can, and by open pods we mean we open up our fences and we say, everybody come in, right? Come on in, we're going to help. And that's because the commander may have to shut down the military installation. You can't just have free inflow, security reasons. We don't know, we can't always control who comes in and out, okay? And with that being said, we can open those gates for all of our beneficiaries, and we can help provide countermeasures and support for all the beneficiaries in the community. And this is an important thing to know because, you know, your local public health department's planning for that population in the community. You can take care of the beneficiaries inside the fences for these closed pods and so forth. But there's also discussions how DOD could assist the open pods, if you will, in the community under certain circumstances. So it just can't be inside the base. And then this is just the key points to wrap up slides. Again, it's a two-way street. If you're not hearing from your DOD local folks, reach out to them and engage them. And, you know, there should be ongoing dialogue. And again, we're continuing to push this in these courses and through communications at all the installations. And again, we've got to work together. DOD can provide all the medical countermeasures for all their beneficiary populations. We went over the closed pods, the RSS sites, and SMS issues. And again, PHEOs and NIMs are the best POCs. So I'll close it down. I'm sorry I went a little bit over, but I hope that answered.
That's fine. Yeah, that's fine. Thank you. You know, we'll have questions at the end. So I know you were throwing a lot of information in already at different angles, but take copious notes, and we'll pepper these folks with questions at the end. So.